Assalamualaikum warahmatullahi wabarakatuh, and a very good day to everyone. As for today, it is going to be, I would say, the last H5P asynchronous teaching and learning methods I'm going to give to you. And for that, this is going to be going to cover the topic of lung disease and dysfunction. All right, and also we're going to look into how exercise will help in improving patients with lung disease and dysfunction on their well-being and functional daily life. So, but that part I'm going to cover in my next part 2 lecture of this topic. But for today, I'm just going to cover the some introduction of this topic, and then a bit of the pathophysiology of lung disease and dysfunction. Few illness or diseases that can be categorized as lung disease and dysfunction. So yeah. So a little bit of introduction. In our country, lung disease and dysfunction is not as high like other countries in the Europe, UK, and US. In Malaysia, it was spotted by Malaysia Lung Association. Only 4% in our population, the Malaysian population, are I would say suspected or infected with live with chronic respiratory disease, and this is reported by the WHO as well. And lung disease can be due to several illnesses listed in this slide, which is asthma, chronic obstruction pulmonary disease or COPD, tuberculosis, TB, lung cancer, bronchitis. But however, the first two is the most common prevalence out of this 4% in Malaysia, and this is due to things that you can control, due to certain factors that you can control, mainly because of habitual of your smoking, and also factors of your working as well, like exposed too much with silica or other chemicals that can increase the prevalence to get COPD. And then for this topic and this for this chapter, as I mentioned, we will discuss on how exercise can help to improve the well-being of a person who infected to these, especially for these two lung disease that I mentioned earlier, which is the asthma and COPD. So the etiology of the disease, cause of asthma is still unknown and doesn't have any age limit, meaning that it can infect, it can come through to any sort of age level. It can infect young people, middle-aged people, and also older people. While COPD primarily infect middle-aged population, it's due to chronic exposure of tobacco because of lifestyle, as mentioned. The factor could be because of chronic exposure of tobacco, and also occupational factor, coal dust, silica, stuff like that. So yeah, so class worker are the one who usually expose this to this kind of illness. Okay, and out from that, there's non-control factors as well that could potentially infect a patient. Is due to heredity, and for this illness, I mean particularly for COPD, it will worsen over time. It will become severe and severe throughout times. Okay, so yeah. And then let's go through the pathophysiology of COPD. So COPD is the type of disorder characterized primarily by the destruction of the lung vasculature or parenchyma, and dysfunction of the small and large airways. So that's basically the factors that makes the airways of your respiratory system obstruct due to COPD. It's because of the the narrowing of the airways, okay, of your large airways, and also vasculature of your the muscles that helps or assists your inhalation and exhalation. Okay. And usually COPD patient is diagnosed by spirometry and also a few symptoms that develop throughout the course. And for that, it would lead to weight loss, cachexia. Okay, weight loss, cachexia meaning that deteriorating of your well-being. Okay, and then also muscle dysfunction, particularly your respiratory muscles, which are like diaphragm, intercostal, and other supporting for heavy breathing, like sternocleidomastoid, pectoralis major and minor. Those sort of respiratory muscles that assist for you to breathing will become atrophy, become less efficient, or cachexia. And the mechanism of muscle dysfunction among COPD is also not well understood yet. Okay, what caused the muscle dysfunction among COPD patient is still questionable. But however, both respiratory and peripheral muscles shows alteration in muscle mass. For those who impacted by COPD, their muscle mass will reduce, and they also experience muscle fiber alteration in their muscle fiber, meaning that type 1 and type 2 will be changed a bit because of COPD, and I'm going to explain you later why. And also the metabolic function of respiratory muscle also is altered, change. So this is the morphological and metabolical changes in quadricep and diaphragm of patient with COPD. Okay, these are things that I mentioned earlier, alteration that happen if if the person's infected with COPD. Okay, if you notice here, the proportion of muscle fiber type 1 muscle fiber decrease in peripheral muscle, and increase in respiratory muscles. Okay, the proportion of, if you do biopsy in the diaphragm, okay, in the diaphragm, particularly the respiratory muscles, diaphragm, you will see an increase in type 1 muscle fiber compared to type 2. Increase in muscle fiber type 1 compared to type 2. Okay, this is because your body or your particular muscles has experienced in prolonged a chronic struggle in breathing activity, will leads to increase the endurance component of metabolism within your respiratory muscles. That's why it increase in type 1 muscle fiber and decrease in muscle fiber type 2. Okay, meaning that the inefficiency of breathing activity become higher. Okay, meaning that you have to force your muscles, your respiratory muscles, for you to breathe, and this will increase the endurance of the muscles involved. That's why you will see increase in type 1 muscle fiber whilst reducing type 2 muscle fibers in your respiratory muscles. Okay, peripheral muscles, this is the muscles that I mentioned, out from muscle that out from the respiratory system, like quadricep. Okay, quadricep is the peripheral muscles, away from the respiratory muscles involved. Okay, and then size of muscle fiber type 1, although it's increased the proportion, but the size type 1 decrease. Both type 1 and type 2 decrease for both peripheral and respiratory muscles decrease. And this is the things that still scientists have to keep on doing research and get the answer, because there is no certain underlying mechanism why this is happening. But for those who have experience in COPD, infected with COPD will experience this situation or alteration in their muscles. And then capillarization increase, okay, in respiratory muscles. Of course, this is subjected to endurance, meaning that the respiratory muscles demand more effort. That's why it creates more capillary across the respiratory muscles to promote more alteration in the metabolic that demands higher endurance. And then intramuscular pH reduce, meaning that it become more acidic. Okay, because when you respiratory system is very much in relation with our buffer system. Okay, buffering the acid system in our body. So when it become less efficient, the buffer system also become less effective as well. Hence, you will get lesser intramuscular pH among COPD patient. Okay, and then ATP concentration also reduce in peripheral muscle, but no findings has been shown in respiratory muscles. Mitochondria increase in respiratory muscles. This is in line with the muscle fiber increase in muscle fiber type 1 because of the forced breathing, because of the obstruction of your airways, respiratory airways, demand higher effort, and then increase the endurance of your respiratory muscles, meaning that your respiratory muscles need to work more, okay, to compensate with the demand of your daily living. And then aerobic enzyme activity is neutral. Okay, same goes with anaerobic enzyme activities for respiratory muscles, but for peripheral muscles, okay, for peripheral muscles, in this case quadricep, the aerobic activity is reduced, okay, and then the anaerobic enzyme activity is increased. Okay, these are the changes, alteration that happen when a person experiences chronic COPD. So the reduction in muscle mass is proportionately greater than loss of total body mass. So for those who infected by COPD, the muscle mass reduce, although it's still unanswered the reason why this is happening. But muscle mass, peripheral muscle mass reduce. However, the muscle mass proportionally greater, reduction in muscle mass proportionally reduced greater than the total loss, the loss of total body mass. Okay, so meaning that the muscle itself is deteriorating. Okay, meaning that it shrink, atrophy, take charge. Okay, and this is basically, scientists predicted this due to the elevation of energy expenditure from the metabolic and mechanical inefficiency. Okay, metabolic meaning that what I explained earlier, because of the changes in buffer system in the muscles, okay, within the muscles, change, alter a bit the energy expenditure and how the peripheral muscles, utilize energy, and then also mechanical inefficiency, meaning that the obstruction in your airways because of could due to bronchocontraction, okay, the obstruction or mucus developed within your respiratory airways. That's what it means by mechanical inefficiency, meaning that your respiratory system need to force breathing, okay, do forced breathing. So in a way, it will increase the energy expenditure, and that could lead to scientists predicted that could be the reason why muscle loss, happen in COPD patient. Okay. So apart from that, systemic inflammation, okay, may contribute to the hypermetabolism at rest, meaning that even during at rest, because of the systemic inflammation in your airway, okay, in your respiratory airways, could lead to hypermetabolism even during at rest. Okay, meaning that the metabolic is high, okay, in COPD patient, and this could lead to loss of muscle mass and loss of total body mass of the patient. And then release of pro-inflammatory cytokines by neutrophil and macrophage may contribute to cachexia. Okay, cachexia means less efficiency in body function, weakness and deteriorating of the body due to severe chronic illness. Okay, so release of pro-inflammatory cytokines, because when a person get COPD, usually there's inflammation will happen, okay, in the airways, okay, airways of your respiratory system. And when inflammation happens, our body, our mechanism, our body will fight back the inflammation by producing more cytokines, neutrophils and also macrophage in that particular area, and this will cause cachexia. And it also has been shown by many scientists that a combination of both nutritional and exercise has been shown to give a positive progress to patient of a patient who infected by COPD, by increasing or improving their functional daily activities, because COPD has no cure, no vaccine, no medication. It's just you have to improve the quality or the functionality of the person's muscles and well-being in order for to lesser the symptom, to make the symptom manageable, and to prolong life, of course. And however, although patients who infected by COPD encouraged to perform exercise, you have to keep in mind that there's a limitation that listed in here in this slide. You have to keep in mind so that you are aware, you are not over limit them or over exercise them, and at the same time you are progressing them, making the training progresses within their capacity themselves. So these are the limitation of exercise among COPD patient. Increase inspiratory muscle work, okay, meaning that your inspiratory muscles, okay, have to work double in order to get in the air into your body. So the muscles have to work double for that. And then inspiratory muscle weakness, dyspnea, okay, or shortness of breath because of the blockage or obstruction of the respiratory system. Early lactic acidosis. This is because of inefficiency of the acid buffer system, because it's very much in relation with our respiratory system. The respiratory system and acid-base balance is work together hand in hand. You have to read this back in your anatomy and physiology course, so to get the better understanding of why and how this happened. And then increased ventilatory demand relative to capacity. Okay, because the body didn't receive enough oxygen supply. Of course, the demand is higher. Okay, because if you remember, the percentage of muscle fiber type 1 is increased among among COPD patient, and then as you know, type 1 demands more oxygen. Okay, but the demand is high but the supply is less. So yeah, so end up for the person to increase the ventilatory demand. Okay, and then gas exchange abnormality. Okay, dynamic airways compression. Okay, because of the obstruction happen. And then expiratory flow limitation because of the inflammation. The expired air, difficult to totally empty the lung, okay, because the obstruction. And then of course this is something to do with cardiovascular factor as well. It can affect the cardiovascular factor, okay. Of course, cardiovascular and also respiratory system work hand in hand. It will affect the cardiovascular system equally. And then peripheral muscle abnormality. This is one that scientists still trying to find the answer. Peripheral muscles, muscles out from the respiratory, away from the respiratory system also is affected due to COPD. And low lung recoil. Okay, the lung doesn't really recoil, rebounds back to its normal when you exhale. Okay, when you exhale forcefully, the air inside your lung will find it hard to empty itself. Okay, meaning that the lung difficult to empty itself because of the obstruction. So hence, unable to recoil. The ability for the lung to recoil back is lesser or inefficient. Okay, so these are the limitation during exercise that COPD patient will experience. So the greater intensity of the exercise is the greater intensity of dyspnea, meaning that the demand, of course, higher will lead to greater shortness of breath when you perform high intensity exercise. Okay, I'm sure you can understand this because of the oxygen depth. Okay, when you perform high intensity exercise, percentage of oxygen depth is increased. Hence, with the condition of COPD, you will end up having more intense dyspnea. Okay, hyperinflation, okay, which is the obstruction of the airways during exhalation, leading to incomplete lung emptying. This is how I explained earlier. And then hyperinflation flow limits also exhibit muscles, inspiratory muscles, in two ways. Okay, the hyperinflation, it will cause two things. Okay, will exacerbate inspiratory muscles loading in two ways, which are by forcing inspiratory times to shorten. Okay, because lack of demand. Okay, by forcing inspiratory time shorten to allow more times for expiration, which move the inspiratory muscles to a weaker portion of the force velocity relationship. The faster the muscles contract and the lower the force generating capacity. And then the second one, hyperinflation will also happen by generating positive and expiratory pressure. Okay, will increase the positive and expiratory pressure. So it means that the expired end before all of the force acting on the lung are in equilibrium. So inspiration is initiated under a positive expiratory load. Okay, and then for this reason, COPD patient diaphragm muscles must undergo an endurance training. Okay, to make sure the respiratory muscles become more efficient in terms of working on doing breathing activity. So okay, that's that. Now let's look into the pathophysiology of asthma. Okay, so this is a symptom of asthma that includes wheezing. Okay, meaning that their breathing produce sounds. Okay, dyspnea, shortness of breath, and this will be more notable when the persons perform exercise. Okay, and then of course chest tightness and cough, okay, due to the obstruction. And sometimes patient will not have any symptoms unless a trigger factor came across, like exercise. Okay, it can be also other factors, for example what they call it, certain chemicals or certain pollens of a flower. Okay, that can be the factors for the persons to to have asthma. So trigger the asthma to happen. Okay. And then asthma patient respiratory airflow may be narrowed due to incursion of the airway lumens meaning that narrowing of the airway lumen due to edema, okay, accumulation of water, okay, within the smooth muscles fiber in the airways, and accumulation of mucosa, and then a contraction of airways muscles as well. Bronchocontraction, okay, meaning that the airway contraction is shrinking, contracting. But this is not as severe as COPD, of course. It doesn't happen in a prolonged manner. It will relax in due course, and the times of contraction also be shortened if you take a medication, inhaler. So the abnormalities are similar like COPD, but with few differences, and the differences are, asthma, less reduction in static lung recoil, as I mentioned just now. For those who have COPD, their lung ability to recoil back, okay, when the person's breathing is lower, the ability is lower, but not in asthma, okay, because the obstruction doesn't really infect until the deep inside the lung. It just happened in the surface. Whilst asthma and also asthma do not collapse airways like COPD. It just obstruct. Okay, it does not collapse airways. Okay, it just it make the airways thicker due to edema or accumulation of mucosa, but not collapsing the airways. And then for asthma patient, airways obstruction is not prolonged like COPD, meaning that it will quickly relax, okay, in due time. And then exercise limitation among asthma patient is primarily dyspnea, meaning shortness of breath. That's the only limitation among asthma patient, unlike a COPD who have various numbers of exercise limitations. So when you prescribe exercise among asthma patient, you have to keep in mind that this is the only factor that limit them from doing exercise, and make sure they have inhaler or any medication together with them when they do exercise. Okay. So yeah, for that I'm going to continue this lecture. I'm continuing this video in my part 2, where I'm going to explain more about how exercise or evidence of exercise can become a therapeutic medication to these respiratory diseases that I mentioned, especially COPD and asthma. Okay, and then yeah, thank you very much.